Hey guys, it's Dr. Sara Gottfried. I'm the board certified OBGYN who's the author of several books, including The Hormone Cure, which is around here somewhere. This is the book where I talk a lot about PCOS. There's an entire chapter on it, on high androgen levels and what you can do about it, the supplements that are proven to really make a difference. And even though this book is a few years old, it's still totally current in terms of the science. So that's a place to go to for if you want more resources. Here's what I want to cover today. We talked about how PCOS confers this greater risk of cardiovascular disease to women. And I really want women to care about heart disease because it kills us more often than breast cancer or weight or some of the issues that we struggle with. And then in the second video, part 2, I talked about how I diagnose PCOS, the 3 things that I look for, the 3 diagnostic criteria. And in this video, I want to answer some questions that you guys had about, I'm someone who is lean, but I think I have PCOS, or I'm someone who doesn't have any hirsutism or weird hairs. Is it possible that I still have PCOS? Or I'm someone who has a regular cycle. Can I still have PCOS? So I want to answer some of those questions, although please watch part 2 because I talk about some of those things in that video as well. So I want to talk about the 4 different patient types that I see with PCOS, okay? So the first one is kind of the classical PCOS. And this is from, as I mentioned in the last video, a talk that I gave for the Cleveland Clinic. So it's as if you guys are at the Cleveland Clinic hearing me talk about this. So this first group is kind of classic PCOS, and that's got 3 parts to it. So this is phenotype number 1, patient population number 1. The first part is clinical and or biochemical evidence of high androgen levels. So I talked about that in the last video. That can be clinical, acne, hirsutism, these rogue hairs, or it can be biochemical. So we measure your blood, your testosterone's high, your free testosterone's high, your DHEA is high. Those are clinical and or biochemical evidence of hyperandrogenism. The second part of phenotype number 1, classical PCOS, is evidence of oligo and ovulation. So that's OBGYN speak for having a period that's every 35 days or longer in between. The third is ultrasound evidence of polycystic ovary. So again, I talked about that in the last video. I kind of presented the classic case with some of the variances, so I'd recommend going back and listening to that if you didn't catch it. The second group is called phenotype 2, and that has some overlap with the classical PCOS, but this is based on National Institutes of Health criteria. So these are women who have clinical and or biochemical evidence of hyperandrogenism, as I just described for phenotype number 1, and they have evidence of oligo and ovulation. So the thing that's different here is it doesn't require an ultrasound. So these are 2 different diagnostic systems for diagnosing PCOS. And so I get patients referred to me who've been diagnosed who are in that first group, phenotype 1, and then I have other patients who are in this second group. They've been diagnosed based on NIH criteria. The third group is an answer to your question. This is the ovulatory PCOS type of patient. So this is phenotype 3. And what happens here is they have clinical and or biochemical or blood tests showing hyperandrogenism, high testosterone levels, high DHEA. And then they have ultrasound evidence of a polycystic ovary, but they're having regular cycles. Now those regular cycles, as I talked about in the last video, could be completely normal, or there can be some level of dysfunction going on. In fact, I see patients who've got regular cycles, but they don't have the LH surge. They don't have the luteinizing hormone surge before they right at the mid-cycle before they have their period, right around day 14 or 15. So that's a third group. Some of you asked about this. Can I have regular cycles and still have PCOS? The answer is yes. This is phenotype number 3. And then here's the fourth group, and this is really important because the first 3 groups that I mentioned, classic PCOS, NIH criteria PCOS, phenotype 2, ovulatory PCOS, the third group, all three of these have the greater risk of cardiovascular disease. But this fourth group, phenotype 4, is non-hyperandrogenic PCOS. And these are the folks who do not have an increased risk of cardiovascular risk. They have a baseline risk that's similar to other women, meaning that you got a greater risk, especially after you go through perimenopause and menopause. So this is the group that has evidence of oligo and ovulation. So they're having a cycle that's every 35 days or longer. And then they have ultrasound evidence of a polycystic ovary. So that's the string of pearls sign. I had my pearls on in the last video, and I couldn't think of string of pearls sign. That's the sign we're looking for on ultrasound. So these are women who don't have any problems with their androgens, but they are having irregular periods. They're not ovulating every cycle where they should be. And then they have ultrasound evidence of a polycystic ovary. So those are 4 different phenotypes that we see, because I wanted to make sure that I answered this question, can I have regular cycles and still have PCOS? And the answer is yes. Can I have PCOS but not have acne and hirsutism or a problem with my testosterone? And the answer is yes. That's phenotype 3 and 4 respectively. So I hope that answers more of your questions. Please leave more questions and comments below. Please share this with some people who need to hear it. Any women who are struggling with hormone imbalances, I think a lot of hormone imbalances trace back to an issue with polycystic ovary syndrome. We'll be talking about insulin in the next video. In fact, it's something I won't shut up about because I think it's so important, not just for women, but for men too. And so I want to thank you for joining me. I hope you have a fantastic weekend, and I'll see you next time.